you. I'm Bruna Ventura, and we're here at the 2023 Breskers meeting. I'm having the pleasure of interviewing one more year Dr. Ike Ahmed.
Awesome.
Thank you, Ike, for being
Bruna,
here.
great to be here again with you in Breskers.
You're almost a Brazilian. You have like a Brazilian passport in your bag.
I have some green blood somewhere in there. Yes, exactly.
Thank you for always being here in the meeting, always bringing us such interesting topics, really. And thank you for being always in the edge of innovation and sharing it with us, our colleagues, your colleagues.
It's totally mutual being here. It's an honor. Thank you so much.
Thank you. One of the lectures that you're giving is in a all your lectures are interesting, but one specifically called my attention, that is using presbyopia IOLs in patients with glaucoma. Tell us a little bit more on that topic.
You know, traditionally in glaucoma, because of the known contrast loss, which has been shown in mild, moderate, severe cases, many of us have been a bit shy using lenses that can split light or manipulate light and lose contrast. And this is not an unreasonable point to consider. And my talk was basically just showing some of the evidence around glaucoma and contrast sensitivity, for example. We see increasing loss of severity based on the disease severity, so more visual field loss, more contrast loss. On the other hand, patients who had very early disease and pre-parametric glaucoma don't have as much contrast loss. That's one thing that's important to consider. We also reviewed some of the new IOLs. You know, we see, for example, some of the new multifocal lenses, but the contrast loss isn't as much as we saw in the older models of multifocal lenses. And then we have EDOFs, which are very interesting. Some EDOFs, for example, have monofocal light contrast sensitivity, and others have less halos and glare. So we have so many options available that we were kind of talked a lot about different options for different patients. So my premise was, listen, someone had advanced disease, central fixation loss, or high risk for progression, I steer clear of lenses that manipulate light excessively. Typically it's monofocal, or maybe considering like monofocal plus, like IHAS, for example, or something that's going to be very minimal in terms of contrast loss. Someone on the other hand who's pre-parametric glaucoma, or very early, or suspect and hasn't been progressing, I talk about all the options to patients. I feel pretty confident that the newer presbyopic lenses have a pretty good level of contrast retention. And then patients who maybe are more mild and stable, again, I also feel that patient can benefit from that as well. But patients who are more moderate, or maybe we're not sure if they're stable, I usually am still careful with multifocals. I'll consider an EDOF a little bit. I think the EDOF loss is a little bit less, and so that's where I go with it. The premise again is, of course, I think our patients deserve an option to consider all these possibilities, but we also know we should do no harm as well. And that's the balancing act between deciding those options. I also think it's a bit paternalistic to say, no, we cannot use any lenses for these patients as well. So the answer, I think, is somewhere in between. And we really need more evidence. So we're looking forward to some of the studies that are going to come forward, looking at contrast sensitivity in glaucoma patients versus controls with different lenses. These are coming through. We're going to inform us more about how these lenses can be best used in this difficult population.
Wonderful. We know that many of the drugs for glaucoma, topical drugs, interfere a lot in tear film, ocular surface. How do you see that and these presbyopia IOLs in these eyes?
This is another great point. And you know, particularly patients who are on high medication load, chronic medications, they've been shown to have worse ocular surface, disease than patients who don't. And that has an impact, of course, in our IOL calculations and also postoperatively, in terms of the, corneal health.
Yeah.
Those patients, again, I'm careful because the difficulty in calculations, the difficulty in managing ocular surface can be a problem unless we can manage it together. And now this is where we, for example, often combine MIGS. The benefit of being able to reduce medication load, improve the corneal health, and improve the function of the entire optical system with IOL. So that's the thing that we need to do. I always say any glaucoma patient, we should always be assessing the ocular surface, even without surgery, because this will inform us, again, what the risks of surgery may be and also what lenses to use as well and to try to manage that as well. So again, ocular surface disease, relative caution in these type of IOLs, but for patients we can get off medications or on less medications, again, it opens a door for some of these lenses.
Thank you so much, Ike, for your time and for being here with us.
Thank you so much, Bruna. Always a pleasure. Thank you.